โอเคนะเริ่มได้เลยนะฮะบ่ายวันนี้ก็เป็นไงฮะเมื่อเช้าเซสชั่นใช้ได้ใช่ไหมฟังภาษาอังกฤษทันใช่ไหมโอเคพอบ่ายนี้หมอวิรัตก็จะพูดภาษาอังกฤษด้วย Are you sure English right อันนี้ผมจะพูดเรื่องเกี่ยวกับโรแมนติกหน่อยว่าถ้าคุณไม่รู้ว่าหมออลิสาเนี่ยกับหมอฮิโรชิเมื่อวานเนี่ยเป็นสามีภรรยาเพราะฉะนั้นมากันได้คนละวันหมอฮิโรชิมาเช้าแล้วเย็นก็กลับไปรับลูกวันนี้คุณหมออลิสามาเช้าบ่ายก็ต้องวิ่งกลับไปรับลูกก็เลยไม่มีใครยอมอยู่ค้างคืนแล้วก็เหมือนคุณหมอวิรัตกับคุณหมอนภิษวาดีก็เป็นสามีภรรยาถ้าอยู่ไม่คอนเน็กDavid Strauss going to be your moderator. He going to start.
Good afternoon, everyone. I'm David Strauss, and I'm from Texas Tech University Health Sciences Center in Lubbock, Texas. And I'll be speaking to you tomorrow on microbiology and immunology. Our speaker today is Dr. Virat Pornpanith, and he was born in Thailand and received his MD at the Faculty of Medicine, Chiang Mai University in 1988, and did postgraduate training at the Mahidol University in Bangkok, and also the Facility of Medicine here in Chiang Mai. He has worked at several universities in the United States, including Texas Tech University Health Sciences Center, and even though I didn't know him when he was there, I certainly recognized him when I saw him today. He is presently in private practice in Bangkok, Thailand, and he will speak to you this afternoon on the USMLE Step 2 and 3 in rheumatology. Doctor?
Can you hear me? Okay. All right. Thank you very much for Mr. Chairman and all the organizing committees that set up this workshop today. And I really appreciate that and be honored to be here today and just give you a talk on the rheumatologies. And I would like to stress out that it's some of the point that we can make it today just mainly for the purpose of the get through the examinations. I will not try to cover all of the topics, otherwise we will not finish it today, and we may have to continue that tomorrow. And I hope that everyone will understand that. And I'm not sure whether I should conduct that in Thai or in English, because first I want to get all the information across and don't want to leave anyone behind with the communication barriers. And I hope everyone can catch up. Or you want me to talk in Thai? So silent mean yes or no, or I don't know. I don't want to talk. I don't want to say anything. I just keep it to myself. All right, so I take that opportunities to be in English. So if anyone cannot catch up, so you can look in at the slide later and maybe can review that with the CDs that we provided you later. And I think we'll begin with, okay, just a small talk on the rheumatoid arthritis, which is a common disease that they found in both in the state and in Thailand, and usually that will become in the examinations more or less. Then we show up that commonly you see that the patient will present with the gradual onset, that presented with the joint pain. They will stay like over a week or month. And some people may have what they call the palindromic rheumatisms. That is some indications that the people may have the synovitis that presented on and off over the joint, and they usually go away by itself, and later on this may develop to be a rheumatoid arthritis. Another point to make is the elderly onset of the rheumatoid arthritis. As a common scene that we see that the arthritis is involved in the young adult, commonly in female. However, in the elderly onset cases, usually they presented, like polymyalgia rheumaticus. They may have aching and pain, fevers, malaise, and weight loss, and usually it's predominated in both sex, both male and females. Sometimes you will see rheumatoid nodules, and those presentation is much less common in the elderly cases. And about 20% of the people who have rheumatoid arthritis may have the seronegative, which means we're talking about rheumatoid factors that we call it seronegative case. And about 70% of the people would show up erosions in about 2 years. And here is the slide that's showing the, sorry, I make it too fast. Okay, here is the slide that's showing the typical rheumatoid arthritis that you may see that it involved in the MCP joint, here, all across both hands, and you may see the deformities that we see that in the little fingers here. And anyway, rheumatoid factors might be found positive in another disease, such as like Sjogren's, SLE, cryogloburin, which is very typical in the case that, they will asking the question about the cryogloburin that show very high titer of the rheumatoid factors. And remember that, it's always been in the test. And even though that you may not see that in the real life, in the practice. And bacterial endocarditis that can show the false positive rheumatoid factors, and hepatitis as well. Another test that might come up in the test that we call the anti-CCP is anti-cyclic citrullinated peptide, which is now more specific with rheumatoid arthritis, is about 95 to 90%, and is early predictor for the rheumatoid arthritis. I'm not sure whether they can ask this in the question or not, but usually it's presented in the board of the internal medicines and rheumatology. But nowadays, in the future, this might come up in the test because it's become more common tested in America now, And another area is about the spinal involvement. That you see the C-spine involvement up to 50%, but that found in the autopsy, but clinically it's may not that frequent like what we've seen. And 90 to 70% of those C-spine involvement involve at the allantoaxial subluxations. And basically about 20% may show up with the basilar invaginations, and usually when the people who has a history of rheumatoid arthritis and gonna go or underwent for the surgery, you need to, they were asking the question about what should we do next before the surgery. The answer should be about the assessment of this C-spine involvement. they may asking about the X-rays. Usually it can be like just a plain X-ray or the CT scan of the C-spine. And if the plain X-ray, usually you have to do with the fraction extensions films, because of that only way to see the subluxations show up in the X-rays. Another area that might involve that is the lung involvement in rheumatoid arthritis. The commonly seen is in the pleural effusions, the interstitial lung disease, and the rheumatoid nodules in the lungs. And the interstitial lung disease may be presented as usual interstitial pneumonitis or BOOP, or here this film is showing the pleural effusions that might see it in rheumatoid arthritis. And this small nodule here, you see that is rheumatoid nodules that's showing in the BOOP. Anyways, rheumatoid nodule is one thing that might showing in the picture that asking to see what this look like. Is a lymphoid hyperplasia that with non-specific cellular infiltrations. And some people have a good prognosis if there is a non-specific cellular infiltration in the biopsy. And here they were asking, what is that, Come to the key point about rheumatoid arthritis. That always one or two questions that we're asking. And it's maybe look like in hematologies. They're asking about patient with rheumatoid arthritis and now present with the fevers and the show lab, blah, 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 and you see that they have a low white cell anemia, those things like that. They are love to asking these two kind of disease, the seeing common, not commonly, it's a complication. It's a Felty syndrome. Felty syndrome is a rheumatoid arthritis, and they complicated with the leukopenia, and they had the splenomegaly. These are three key points that you're looking for if they're showing the patient with the rheumatoid arthritis and the blood test show leukopenia, ultrasounds, or you can feel the spleen. The thing about this, okay? And looking at the lab, you will see the neutrophil count is low, and they may have some infection, present with the fever, something like that. And basically, the neutropenia in the Felty syndrome is caused by the immune complex and sometimes is presented with anti-granulocyte antibodies and increasing the blood cell margination and bone marrow abnormalities. And sometimes it's damaged by the cytotoxic lymphocyte that inhibit proliferation of the bone marrow cells, and sometimes they develop those growth factor antibodies that binding to the white blood cell directly. And the common infection in this Felty is a staph. Okay, they may asking that and say what antibiotics you use. Don't forget to cover the anti-staph antibiotics and that. And usually they may associate it with HLA-DR4, and they will present it with high rheumatoid factor and NA positive, and sometimes have antihistone. Another thing that may look like Felty is the disease called large granular lymphocyte syndrome. This is a chronic lymphoproliferative disorder that will present it, as abnormal at the natural killer cells and the CD4. And what happened is they will present it pretty much like Felty syndrome. They present it with the neutropenia, has a splenomegaly. Sometimes they call it the pseudo-Felty syndrome. What the point is, between this Felty syndrome and large granulocyte, they will see the difference is in the bone marrow. If the question asking and you're not so sure, then the answer may be the bone marrow. The bone marrow may filtrate it with the lymphocyte, which is abnormal lymphocyte. You will see that, and they have a large granular inside And this usually is at the onset of the arthritis and neutropenia that's going together. Usually it's presented at the early onset of the arthritis. And the arthritis may be mild, not so bad, like the Felty syndrome, which is a long-standing rheumatoid arthritis. And the rheumatoid factor usually is absent. And they might show the slide, containing with this smear that you see the granulocytes, the lymphocyte that containing with the granule in the cytoplasms. And they were asking about this. Another thing that may be questioned in rheumatoid arthritis is about malignancy. Usually is increased risk of the lymphoma. They were asking what kind of lymphoma is. Usually it's a B cell and non-Hodgkin lymphomas. And they also report the decreasing of the colon and rectal and stomach cancer. And the prognosis, what is a prognosis indicators is number one is the high titer of the rheumatoid factor or nodules that give a bad prognosis, and the low socio-economic status, low educations, and the number of the tender joint, the swelling joint, early radiographic change, and the functional disabilities, number of the surgery, that would be the indicator of the poor prognosis. The treatment, I don't think that it was asking in the USMLE questions, because mostly they do it in the board exams, either in the internal medicines or in rheumatology board. However, they usually asking just a simple thing about the normal, the NSAID, or treating with the those steroid demarked, and including the methotrexate, hydroxychloroquine, sulfasalazine, and the more sophisticated thing is Arava, which is leflunomide, and biologic therapies such as like anti-TNF and anti-the B and T cells interaction, and anti-B cell, and cyclosporin and gold salt. The board question may asking about the complications, which is usually commonly seen it about the methotrexate, hydroxychloroquine, and sulfasalazine. That's also three medications commonly used in treatment of the rheumatoid arthritis. And commonly, side effect from the methotrexate is a liver toxicity. And they don't really asking that much about that, but they always love the rare complication, which is going to be seen that in about lung injury for methotrexate and leflunomide. That may show up the X-ray that look like the interstitial lung disease. That one thing is have to think if the patient on the methotrexate or leflunomide is those from the drugs. Now move on to the spondyloarthropathies. The means of this spondyloarthropathy, including those of the enthesitis, which is the informations of the site where the tendon or the muscles attached to the bone. They were including the dactylitis, which is informations of the finger or toes. They will show up like oligoarthritis or have the extra-articular fissures such as uveitis or mucocutaneous lesions, and commonly associated with HLA-B27. And the criteria that used, the people may present it with back pain that called the inflammatory back pain. They usually present it with the pain, aching, stiffness, commonly in the morning or late at night, And also they usually has one of the following problems that maybe alternate buttock pain, sarcoiditis, anti-soft-party, and family history psoriasis, and IBD is inflammatory bowel disease, and urethritis, cervicitis, diarrhea that associated with reactive arthritis. And the bacteria that may trigger this one is Shigella, Salmonella, Yersinia, Campylobacter, and Chlamydia. So for urea plasma, BCG and the Clostridium is in questionables, not a confirming that. the X-ray, they might showing the abnormal SI joint, that you can see one or the other. They can see one side or both sides. And in the meantime, the other thing that's commonly showing in the test is the osteitis condensa ileis. That is a normal findings, normal variant that you can see that is the bright osteosclerotic of the edge of the SI joint. And the other thing they might see the Paget and Scheuermann and chondrocalcinosis and congenital kyphoscoliosis and fluorosis and onchronosis, Also the TB can involve in the SI joint as well, and brucellosis and hyperparathyroid. Actually, in the spondyloarthropathies, we classify it into several diseases, that may have the different presentations, Number one is ankylosing spondylitis, which is normally seen in the young adult, more common in men more than women, and the ratio now has become less and less, usually they see it in women as well. And the second is reactive arthritis, and the former call is Reiter syndrome. And third is psoriasis and juvenile onset, that is in another category. And the undifferentiated spondyloarthropathies that we cannot classify it in each group. And the other one is associated with the inflammatory bowel syndromes, especially Crohn's disease and ulcerative colitis. Ankylosing spondylitis, they may present it in different features that can involve in the spine or in the SI joint, and some people may have the big joint in the hip and shoulder, and lastly cause to the costal vertebrals, sternoclavicular, and costochondral inflammations. And another thing is those has an enthesitis, and peripheral arthritis is another thing that can seen, and extra-articular organ involvement such as the uveitis. This is a test that looking for what they call the spinal flexibilities. You measure 2 point, from in the spine, and lets the patient bending down and measures how much it can extend it from 2 point. Usually you have to be more than like 5 centimeters. It's called the Schober test. And here is the x-rays that's showing the fusions of this SI joint. Normally you see the space here, and you cannot see that at all here. Reactive arthritis, usually you will see the patient presented with some preceding infections, that can be seen in the enteric forms, from the Salmonella, Shigella, Yersinia, or urethritis. And they may present it with extra-articular, such as like the conjunctivitis, uveitis, may have the oral ulcer, skin rash, that involve in the genital area that called the succinated balanitis. Here is the dactylitis. You will see that this is finger here. It looks like the sausage. They call sausage finger, a sausage hole. The treatment, normally we begin it with the NSAID, but actually it doesn't really work that much, and normally the people would go step more further to using like the disease modifications, sulfasalazines, and methotrexate or go injection. But nowadays, all these treatment may not as effective, So now they step up to using the biologic therapy, such as like, anti-TNF. Regular exercise is very important, and they'll recognize as a one tool that the people, you have to encourage the patient to exercise on the regular basis and no smoking. Antibiotics, does it need to use the antibiotics because we thought that this is a reactive arthritis that may associated with the pathogen, the bacteria. However, they don't really recommend it only in the case that you found the source of the infections. Otherwise, it's not indicated. You know, psoriasis usually is presented with asymmetrical oligoarthritis or symmetrical polyarthritis, and they can show up with the arthritis mutilans or SAPO. I will pass this. Now come to the another disease that usually present in the test, you know, is SLE. They always asking about the questions of those antibodies, you know. Now, this is the antibodies that commonly we do in the patient with the SLE, you know, and you know that the key point is if the double-strand DNA and the SM, which is Smith, you know, and those usually is very high specific for the SLE, okay? If they're showing the test for the anti-histone, that usually think about the drugs induced, and their RNP, you have to think about the MCTD, and the SSA and SSB, more commonly asking about the neonatal lupus, you know, and Sjogren's, and the liposomal P is asking about the psychiatric disease that's seen in the SLE. If you go through the criteria of the SLE, you will see that it's showing all the organs that can be affected by the SLE, from the skin, from the musculoskeletal, hematology, intestinal, pulmonary, renal, cardiac, and neuropsychiatrist and lab tests and treat, and that is involved, you know, in all their organs. And usually, if they're asking the question, they will present the patient who coming with the non-specific symptom first, like fatigue, myalgia, weight loss, fever, hair loss. Those are the questions always presented, and they may show the lab the more specific organs, you know, such as the arthritis may be presented, like, you know, either the migratory that may look like rheumatic fevers, you know, but key point is a painful and non-deforming, you know, they're not causing any erosion. So that is a key point in the X-ray that might show the films, and the people with arthritis and no erosion, that you have to think about this as SLE. And the skin rash, you know, they presented with Mara rash, photosensitivity, and discoid rash. And the renal phenomenon, renal involvement, you show the lab that has proteinuria, and the biopsy is showing the glomerulonephritis, which is, I don't think it's gonna present it in the USMLE, but it may come up in the board exam. For the pulmonary, they may affect the pleura, you know, that can showing with the pleurisy, effusions, or involved to the lung that is caused by pneumonitis, interstitial lung disease, and rarely presented with a pulmonary hypertension unless the tissue has some things involved in the lung first. And the other thing is alveolar hemorrhage. Eye involvement may presented with choroidal conjunctivitis sicca, may have a retinal vasculitis, you know, scleritis, and anterior uveitis. Hematology, they may present with anemia, thrombocytopenia, or leukopenia, especially lymphopenia. And immunology, like I said, that, you know, is showing in the antibodies that involve, you know, ANA, the specific antibodies in that. Another question that usually asking is about the drug-induced lupus. I think just remember the definitely cause. The procainamide, hydaracins, minocycline, diltiazem, penicillin, also penicillamine, INH. For the interferon and meltudopa and carbamazine and Practilol. And usually they asking the question of the people who come in and have underlying disease and taking on some of these medications, such as for antihypertensive drugs or anticonvulsants, or anti-TB, and then develop some disease symptoms that present with rash, fevers, hepatosplenomegaly, blah, blah, blah. And then, they're asking about, what to do. Sometimes the answer would be like stop the medicines because it's a drug-induced, or maybe sometimes asking about the serology test, what test you should do, or looking for, some you have to do for the antihistamine. For the probables, I don't think that it is very important because it's on the list, such a long list on that, phenothiene, quinine, antithyroid, and antibiotics that, sulfonamide, rifam, nitrofurantoin, or a lot of stuff in there. So I think just for your information, you can review that later. For the GI involvement in the lupus, commonly seen is a pancreatitis, and another thing is a peritonitis, which is part of the serositis. People may have that, not just only peritonitis, they may have like pruritus or pericarditis, but questions always loved the pancreatitis because it can present it with like hemorrhagic pancreatitis. They present with the stomach pain and have the blood test, low white count, and asking what you should do next, about the test, and always think about the ANA. And another thing is chronic active hepatitis, which is autoimmune disease, that can cause the autoimmune hepatitis. I think yesterday, Dr. Sin already reviewed about that. Usually they presented with the very high of the elevated of the ALT, ST, and you will have the anti-smooth muscle antibody positive. Neurological can present it with the cognitive dysfunctions, organic brain syndrome, psychosis, seizure, headache, many things, For the cardiovascular, they can present it with pericarditis and endocarditis. For those suspicious of the endocarditis, especially is a non-infections, the cultures become negative, have to think about the Liebman-Sachs that are more commonly associated with anti-phospholipid antibody syndrome. The anti-phospholipid antibody syndromes that usually can present it with the thrombosis, and occur in the venous size or the arterial size. And they may have a history of the pregnancy loss, the fetal loss, and may show up in the blood with the thrombocytopenia, and the skin may show like livedo reticularis that show on the skin, and the lariat caused by the chronic leg ulcer. And the test that might showing in the anti-phospholipid antibody syndrome is they usually has either the lupus anticoagulant or anti-cardiolipin antibody positive. But nowadays they may showing on the test about the beta-2 glycoprotein 1, where it's another antibodies that's more specific, better than those two tests. But anyway, the pitfall is about the lupus anticoagulant. You have to remember that if the patient's on the anticoagulant, it may cause those lupus anticoagulant positive as well, because it's always showing as part of the anticoagulant. However, the test that more specific or more helpful in those people who are on anticoagulant, that you should do the anti-cardiolipin antibodies and beta-2 glycoprotein 1. Now, vasculitis, that's another area that usually showing the test and then show the pictures, such as earlier you've seen that the hematuria is part of vasculitis that can be seen. And the commonly seen is a hypersensitivity vasculitis that we're showing like the palpable purpura nodules and predominant in the lower extremities and cell-limited, and the biopsy is showing the staining of the IgM, and those usually has association with the medications or the infection. The hematuria purpura, that is loved for the USMLE. They're always asking this question either in the pediatrics or in the adult. The hematuria purpura usually present with acute onset purpura. That is a key point. You see the purpura, you have to think about the hematuria, but always looking for something else. The clue is abdominal pain. Has maybe renal involvement, that you will see the abnormal in the urine test. They may have the arthritis, arthralgia, and usually it's self-limited, about 2 to 4 weeks. And treatment indicated if they have the GI involvement or the nephritis. CNS vasculitis, that is another difficult area, that for all, not just the student, resident, even the staff, or in the practice, it will be very, very difficult to manage, to diagnose, and they're asking questions about when you need to think about the vasculitis, when the people have the serious and life-threatening conditions that end up with a coma, or presented with the headache, and they have later on developed mental status change, or later on found to have the seizures, and the clue has to be based on the imaging, such as like MRI, MRA, or angiograms that will showing some abnormal blood vessels, and then the biopsy may be present, and you have to think this could be the vasculitis. And the treatment have to be used both steroid and the cyclophosphamide. Polyarthritis nodosa. This is another issue that always come up, in the real life and in the bedside teachings. Is this a necrotizing vasculitis that involved in the small and medium size? And the other thing is the key is hepatitis B, that usually is seen, the people who present and they show the test that has a hepatitis B virus present in the blood, either from the carriers or the chronic hepatitis B infections, that have to think about the polyarthritis nodosa. And it can evolve in the peripheral nerve that may be presented like mononeuritis multiplex and has a kidney involvement, skin and GI involvement. Wegener, that is another thing, is a necrotizing granulomatous vasculitis too. And it can involve in the upper and lower tract and the kidney. And the key point is about the anchor. The anchor is usually is the C anchor that is very important in the diagnostic. Usually it's become positive. But anyway, always asking about biopsy, okay? Because the C anchor can be false positive. Polymyalgia rheumatica and the giant cell arthritis, usually presented in the elderly people who come with the aching pain, predominant in the shoulder, in the pelvic area, and always looking at their eyes, to see whether any eye problems, visual loss, ischemic optic neuritis, And, if doubt, before doing any procedures, especially biopsy, you have to think about the steroid. Okay, if any case you doubt about that, start the steroid is indicated. And usually the gap between the steroid and the biopsy is about 2 weeks. You have 2 weeks time after the steroid initiations, then you can do the biopsy that not change the pathology. Mixed cryoglobulinemia. The triad is purpura, arthralgia, and weakness. And usually it's associated hepatitis C, usually it's active hepatitis C. When you found a hep C positive serology antibody HCV, don't forget to do the PCR for the HCV to confirm that. And it can, in the renal, it can present it with membranophoproliferative and involved in the nerve that peripheral neuropathies and hypocomplement. The treatment has to begin with the interferon alpha for the hep C. Now I will go in downward, so I will rejuvenate to be in pediatrics rheumatology, because it's not covered by Dr. Alisa's earlier about this, and they asking these questions in this area as well. JRA is a juvenile rheumatoid arthritis. That is common names, but usually they're using different names sometimes. But anyway, just for our the same understanding that we're still using the old terms, that is a JRA. It will classify into 3 groups. Number 1 is group that involve as what they call the palsy articular, that has involvement of the 4 joint or less. If more than 4, that you call it the polyarticular groups. The other one is seismic form that involve the whole body, the seismic that we present with the fevers that we call the Still disease. And key is the symptom has to be more than 6 weeks, and the child has to be younger than 16 years of age. And another thing is the uveitis, uveitis that found about 40%. In that involved in the eye is not really correlated with the joint. So basically it can be presented separately. Don't forget eyes. And usually they have rheumatoid factor negative, and the low titer of the ANA. Only small group, especially in polyarticular, may present with the rheumatoid factor positive, and later on, when they grow up, they will change the pattern to be like rheumatoid arthritis in adult. But generally speaking, the JRA is not rheumatoid arthritis in the children. It's totally different entity, okay? But it's using the same name, but usually it's not the same, okay? JRA has a good prognosis, except the group that has a polyarticular involvement, positive rheumatoid factor that can change and turn to be like in adult form. Okay, and the polyarticular type has a poor prognosis more than the oligo polyarticular groups. And the seismic onset, usually they're asking this fever, rash, that they call the pink salmon, appear during the fever, and disappear after that. The people will doing well, after the fever is gone, you will find the patient has a lymphadenopathy, hepatosplenomegaly, arthritis, and elevated acute phase reactants, ESR, CRP, ferritin. Those are the abnormal lab tests in the seismic onset. However, one thing has to be including the differential in the seismic onset is leukemia. All the patients present one you think is a seismic onset has to go to the bone marrow to rule out leukemia. And also the children, you can see the hematuria purpura as well, like what Dr. Arisa presented earlier. Now, okay, another one, Kawasaki. That is the disease that always come up, like Dr. Arisa showing it, fever 5 days, and the age under age of 5, and found lymphadenopathies, look at the eye, conjunctivitis, and strawberry tongues. That is another clue that may present it in the test. Rash, and the swellings in the hand and feet, and the peeling, of the in the fingertips. These are the clue to think of the Kawasaki syndrome. Kawasaki disease, sorry. And the complications that might seen it in Kawasaki is aneurysms of the coronary that far about 40%, that can be demonstrated by the echo. And the prevalence of this aneurysm will decreasing after the onset. You will find in the first month about 20%, and 10% in 2 months, and the 1 year will find about 5%. And the potential life-threatening complication is a rupture and the myocardial infarctions that don't. And the treatment has to be given by the IVIG. Now, this is another one, that the parvovirus B19. And it's showing in both in adult and pediatric cases. The parvovirus is the virus that, commonly taught in the practice, but rarely seen it. It's just been discussing, but never been diagnosed in the real life. They presented with, in adult, they presented with symmetrical polyarthritis that look like rheumatoid arthritis. It's pretty much similar together. And in the children, you will see like, that we call the erythema infectiosum, like fifth disease. It's like slap cheek. You see that in the rashes over the cheek that they see. But in adult, rarely seen the rash. They presented with the polyarthritis. But the point is, it's non-erosive, it's non-deforming arthritis. They rarely cause the deformities, and it involved, in the large joint, in the knee, in the wrist, sometimes in the small joint, the fingers and hands too. Diagnostic has to be based upon the blood test that you can demonstrate that the serology that doing by the IgM antibodies to this virus, and usually it's rarely being diagnosed because those antibodies doesn't show up early. Usually it takes about 2 or 3 months to show up on the test. So it always be in the test, but rarely seen it in the real life. And the key point you're always asking is about the aplastic crisis, pale red cell aplasias that can be seen as a complication from parvovirus. Usually you're going to have to looking at that, when they're asking the questions, and they may have the bone marrow suppressions at another cell line, but commonly the red cell. GC, that is another one that asking, usually this is disseminated GC that presented with the joint pain, arthritis, and the key is the skin. They always presented with the skin, and the clue is there has to be like base, erythematous base, and has a pustule, on the top. That is the clue. And the joint can be involved like monoarthritis, but sometimes they can present it more like the polyarthritis, migratory polyarthritis. And another common finding is a tenosynovitis. So they involve not just only in the joint, but attacking at the tendon sheet as well. They will see the whole hand swollen that is from the tenosynovitis. And the bacteria is like is Neisseria, and you have to do the culture from the genital urinary tract or the joint, or rectal area. Don't forget, because in that is seen it in the homosexual. If they say about homosexual, don't forget rectal swab. And the treatment is ceftriaxone, and the culture may find about 40–50% positive. So diagnosis is become upon the clinical findings. Lyme disease, that is another thing that we never seen in Thailand, but always in the test, because that has been talking more and more, because the spreading of the disease, not just in the not just in the east sides of the country, in the state, now it's coming into the Midwest and in the South, Lyme disease is caused by a spirochete called Borrelia. And this spirochete is in the thick. This thick is hard thick, okay? It's not the thick that in the dog. Usually this is in the animal, the wild animals. And commonly it's in the deer. And there is a three distinct spirochete in that, that is Borrelia burgdorferi and alzheimer's and carragini. And they presented by 3 stages. At the beginnings, they were presented at the early localized disease that involved in the skin. And this later it's become a disseminated disease. And last will be the late Lyme disease. What happened in the early localized disease? They were presented with the skin lesions that called erythema chronicum migrans. What it look like? It look like the skin rash that has the red on the edge of the rash, and the center of this rash will become clear, and this rash spreading, they will spreading out from the center. That's why they call it erythema chronicum migrans. And sometimes they usually has this rash at the site of the tick bite, okay? And sometimes they have a smaller one at a different area, but usually they have only one big rash. And they presented with the flu symptom, and the blood test may showing like spirochenemia that can be seen in the blood cultures. And arthritis will be very mild and has some lymphadenopathies, and sometimes the clue is testicular swelling. Okay. Once it's spreading from this point, it's become the early disseminated, which is spreading to throughout the whole bodies. The common involvement is in the heart, that affecting the myocarditis, pericarditis, affecting the conducting system in the heart, that affecting the AV nodal block, or caused by the LV dysfunctions, cardiomyopathy, affect the nervous system, that causing meningitis, septic meningitis, lymphocytic meningitis, and reticuloneuritis, cranial nerve neuritis, uveitis. One clue on this is if they presented with bilateral Bell palsy, not many diseases that cause that. If they're asking the patients who presented like bilateral Bell palsy, think about Lyme disease until proof otherwise. Okay, the question asking like this many, many times. Leg disease, it involves in the joint. They can cause monoarthritis or oligoarthritis, and usually asymmetrical, involved in the large joint, and they affecting the brain, causing encephalopathy, polyneuropathies, and sometimes it's caused like demyelinating disease, CIDP, and rarely causes this acrodermatitis chronica atrophican. It's just some skin disease that not commonly seen it. But acrodermatitis chronica atrophican is common in Europe, not commonly seen in the States, and I don't think it will show up in the test, but just for your information, Treatment, one thing is the congenital Lyme disease. There is no congenital Lyme disease. People think it's a spirochete. What happened if why it's not acting like another spirochete, like syphilis, but we don't know why. But so far has no report on the congenital Lyme disease. The treatment based, you have to give the intravenous antibiotics in the case has a severe. Severe means involved in the heart, involved in the nerve. Neurological disease, heart is carditis, AV nodal block, and meningitis, and refractory arthritis. For the oral antibiotics, it can be used, in the mild case, and usually once suspicious of the Lyme disease, always they're treated with the oral antibiotics first, unless you see it's a severe case. The common antibiotics used is doxycycline, tetracycline, amoxicillin. Erythromycin is recommended but rarely used. Usually they're using azithromycin or clindamycin, even though that it's not the FDA approved yet. So basically, erythromycin not gonna be in the exam. Usually it's like with the doxycycline, tetracycline, or amoxicillin. How long you need to give the antibiotics? Had to be at least 3 to 4 weeks. 3 to 4 weeks, And usually they say that it's curable if you treat at the early onset of the disease, especially in 1 month, but rarely been diagnosis at the time because you're not gonna, basically those people will present it with a skin rash that can be seen easily. But otherwise, if you're coming with the heart or the joint or the nervous neurological problem, usually it's become late for that to be cured. Sarcoidosis, that is another one. It's a chronic disease that involves multi-organs. Looking in the pathologies, it was showing what they call the non-caseating granuloma, commonly affecting the lung. The lung is a common cause, lung and the skin, sorry. There's a two sides, that usually presented in the lung and the skin. And the visceral organ also can involve, Joint is another one that can be seen, but commonly is in the acute arthritis in the early stages of the disease, But what we commonly see is symmetrical additive, that because of people come to to be recognized this sarcoidosis late. You know, you after get through so many tests, you know, before coming to see a rheumatologist, then usually this diagnosis after exclusion so many things before. The skin lesion commonly seen is erythema nodosum. Okay, however, erythema nodosum caused by many things. You know, when you see the skin lesion, it doesn't always sarcoidosis. Okay, but if you see the skin lesion and also has the other organs involvement in the lung, you know, in the nerve, or has some joint, you know, think about sarcoidosis. Okay, and had bilateral adenopathy that's showing in the lung.
All righty. We're going to take a 5-minute break and come back and hear the rest of this fascinating lecture.
Wake up, wake up.